My name is Jeff Tennant. I'll be moderating the session today. I wanted to inform everyone on the session that this session will be being recorded. If you're not willing to participate in a recorded session, you are now informed and may log off if you would like. So, as I mentioned, my name is Jeff Tennant. I'll be the moderator today. I've been in healthcare IT consulting and revenue cycle consulting for over 25 years. I consider myself a recovering CIO. I feel that I have led numerous organizations through significant change in their revenue cycle processes that have resulted in millions of dollars of either savings or additional revenue to their bottom line. Our panelists for today's discussion are Dr. John Paul Jones. He has been in healthcare for over 25 years. He's a practicing physician, has served in many roles, including former CMIO for Centra Health, been a medical director for CPOE, has served as medical examiner. Dr. Jones is recognized throughout the country as a thought leader, as well as internationally, as he has presented on numerous topics, including EHR adoptions throughout the country and abroad. Our other panelist today, Lori Mandozzi. Lori has well over 20 years of experience in healthcare, beginning with her years as a medical technologist, and now is nationally respected for her thought leadership, both in clinical process improvement, executive strategic advisory services. And Lori today leads our EHR HIS practice here at ROI, where she provides services to numerous clients running Cerner, Epic, Meditech, and most of the major EMRs. So let me tell you a little bit about ROI. We're sponsoring this session today. ROI is proud to be a best-in-class organization. We have been working closely as a trusted partner with our clients for over 20 years. ROI is headquartered in Atlanta, Georgia, and we take a focus thinking that as our partners succeed, we also succeed, and our partners' success is our success. We are truly viewed by most of our clients as a trusted partner, and we work very closely with them. ROI was founded on a very special set of skills around project management over 20 years ago, and has continued to grow in a controlled manner, expanding our services. Today, ROI offers services in all of the areas: HIS, EHR, revenue cycle. We have a very large ERP practice as well. We work with organizations on strategic IT planning, as well as other important areas. We work with them on their roadmaps. We work with them on revenue cycle process improvement engagements, providing assessments, and then subsequently the long-term sustainable change to help drive improvement to their bottom line. We also have an area of our business that provides staff support, both short-term and long-term staffing, legacy application support, and we can provide data retrieval and application management services. So in today's presentation, what are we going to talk about? We're going to talk about physician burnout, and primarily, how do we recognize physician burnout? How do we empower those involved to do something about it? And how do we deliver and/or deploy the changes that are identified as needing to be done in order to reduce physician, or we should say practitioner burnout, that is attributed to the EHR and the burden that places on some physicians? Hence our code word here of code writ. So as we look at burnout, Dr. Jones, if you could, would you please provide your perspective, both as a practicing physician and also as a hospital CMIO? Share a little bit of your perspective around what burnout is and what can be done about it.
Certainly, and thank you, Jeff, and thank you for the opportunity to speak. So burnout is, in some ways, it's a little bit like the weather. Everybody's talking about it, nobody's doing anything about it. And when I see this, it's really at the front line when I'm looking at the turnover as recently as 48 hours ago when I had another um, provider leave a practice that I was the director for greener pastures, when I'm having crucial conversations with providers because of patient satisfaction or dissatisfaction is closer to it. And so it is also affecting me as a frontline physician practicing when I see patients that are leaving the practice that are not kind of following what's been directed, in partial due because it's hard for a burned out physician or provider to engage the patient when they have become disengaged, and that's one of the aspects of burnout, that mental distance that kind of kicks in. You add that with kind of reduced efficiency, and it becomes really readily apparent.
Thank you, Dr. Jones. Lori, as one who's worked with organizations over the years in EHR adoption and operational efficiency, what can you share that you've seen that can have an impact on physician burnout or even clinician burnout? And what are things that you've seen that are effective in reducing that?
Thank you, Jeff, and thank you, Dr. Jones. From my perspective, I think it's incredibly important for hospital systems to start at the beginning. And what does that mean? It means that you need to have an honest assessment of where you currently are. And what is the current status of the perception of your technology, the adoption of your technology, and what kind of feedback are you getting? Because these are all indicators of burnout. And do you have an accurate documentation of the real work processes that are occurring within your health system? This is imperative. When the initial implementations were performed, an assumption was made that the technology was going to make everyone's life better. It was going to improve the work processes. It was going to make everything easier. And when that wasn't the immediate outcome, the health systems experienced physician pushback. Because oftentimes the work processes that were being pushed out to the providers were more challenging. The education was insufficient. And it translated into physician burnout and drops in revenue. The immediate reaction by the health systems was to keep changing the technology. But unfortunately, many times this was more cumbersome to the end users because oftentimes these changes were developed and designed and deployed within silos. An example, will that hard stop in the ED application work to drive the work process, or will it be more of a headache? Will the additional note needed to capture language for the bill mean more work for the provider or duplicative work? Are the providers even fully aware or even fully trained on the changes? What I have seen to be successful begins with health systems that pull together robust change strategy that begins with how are you going to define your success? What will that look like? What are the numbers, whether it's your adoption analytics, your revenue success, patient satisfaction scores? And who are your influencers in that? And how will you continue to monitor those and continue communicating these goals? In addition, there needs to be an honest evaluation about your current change control process. If it's IT only, you're set up to fail. It needs to be a true people, process, and technology strategy with a governance that is needed for that, and an optimization plan. And a large component of that is communication. And finally, a strong feedback loop that ensures that end users feel heard, which is a basic ITSM measure. All of this drives to the sustainability of the progress through education, measurements, and feedback. That's what
Thank you, Laura. That was very, that was very, very helpful. So Dr. Jones, as we think about burnout and how we recognize the symptoms or the indicators that we have a problem as an organization, what would you share as the key areas to focus on?
The first thing that really occurs is kind of recognize the scope and the impact of the problem. And I think looking at the list of those that did sign up for the call, I think those of us in the CMIO role, CIO role, as well as practicing physicians, recognize that, but those maybe at the executive level that really kind of determine the resources that are devoted to something may not be as cognizant. So what may seem obvious to you, you need to be prepared to make that case on the true impact. And that case is substantial. When we're talking of 400 plus physician suicides a year, and it's hard to find a community that's not been affected by something as severe as that. If you look at the turnover in various communities as far as providers go, that is attributed to, or at least connected to, a level of dissatisfaction or burnout. We're working in a medical system, a medical environment that really requires doing less with more, and rewarding efficiency and punishing inefficiency, and recognizing what a detriment burnout can be for that. Also, we're getting into kind of a pay for performance world, and have lived there for some time. So, measures of patient satisfaction, not only as far as repeat visits, but direct satisfaction itself, can also affect the bottom line of whatever health system or scenario that you're practicing in. More concerning is that the burnout can contribute to increased medical errors. We already know that a substantial number of injuries and deaths every year, particularly in the U.S., is attributed to preventable medication or medical errors. The environment, the overlay of reduced engagement, decreased efficiency, and just detachment that kind of constitutes burnout can contribute to that scenario as well. And the stats are really astounding when you find some places that report that greater than 50% of all providers have at least one symptom of burnout. And that is staggering. Thank you, Jeff.
Thank you, Dr. Jones. So as we think about patient satisfaction, and most organizations send out a satisfaction survey, would it be fair to say that if we review the comments of those returned surveys and look for key things like, I felt like my physician or my provider didn't spend enough time with me, wasn't focused on me while we were together, seemed to rush, would those be indicators that there may be an underlying issue related to burnout, even if it hasn't surfaced yet as complaints, or even like you mentioned a moment ago, the catastrophic things loss of life or medical error?
Yeah, I think I can in part. Oftentimes a patient experience is that the experience of the entire encounter of care. And so even if they've reported something other than a provider being distracted, then that may be a tie-in as well. Because although the focus of this presentation is physician, or more accurately provider burnout, it's really disseminated through the entire care team. That's the nurses, the clinical staff, and the non-clinical staff that's around. And all of those impact that patient experience.
Right, and you spoke a little bit about the cost and loss of life, but as a former hospital CMIO and one who dealt with bringing on new physicians, if you have to replace a physician, I know there's a lot of cost associated with recruiting and bringing a physician on board. What are the other associated costs, or what are the timelines around a new physician or a new physician to your organization really being up and ready to function? I mean, are you looking at a month, 6 months? What would the typical timeline be?
Generally for a new physician to reach baseline production compared to the peer group in that area, it runs 6 to 18 months, really depending on the specialty of the area and that individual. And the other aspect of it is every health system, CMIO, CIOs in particular, have that challenge for, the next upgrade, the next application, the next EHR renovation. And having an audience or target or end users that cite EHR utilization or use as a primary or high cause as far as dissatisfaction and burnout, that's a tremendous challenge. And there will always be changes in the EHR, whether it's advancements or the new initiatives or rules and regulations. And to add that barrier overlay on a tremendous job is difficult.
Thank you. That's very helpful. So, Lori, as a go ahead.
I'm sorry. And kind of getting back to a little bit earlier point that you've got to convince the health system, the executives, to devote the resources to that is challenging. Unfortunately, at that level, they often have the approach of build it or buy it, and they will come. Well, if you're not incorporating the resources to address the education and engagement, and we'll get into this a little bit later, then it's less than full utilization, which is a shame. Thanks.
Right. Appreciate that. So, Lori, as a clinician, someone who's worked in the hospital and has been on the other side of it, not necessarily a practitioner, but a medical technologist, what are the signs that others in the organization may be feeling frustrated or feeling burnout? Burnout doesn't just affect physicians and practitioners, and the burnout around others in the clinical environment can have an impact on patient satisfaction as well.
Absolutely, Jeff. And going back to the cadence of this presentation of Code Red, we're in the recognized portion of this, and we'll be talking about empowerment and deployment, because it's absolutely imperative to accurately recognize what's going on in your health system. And that's where we are in this conversation. And as Dr. Jones and you, Jeff, pointed out, physician burnout has multiple symptoms. And when you're talking about those symptoms, those actions have collateral damage within your system, because the focus is often on the providers, as it should be. But we need to remember that the technology has made the provider the driver of many of the work processes within the system. And that with physician burnout, that can have a systemic impact on the health system. How many work processes within your health system are impacted by the provider lack of adoption and understanding of the system? Examples include, and I know this will resonate with our audience, discharge processes, transfers, medication ordering, referrals, result reviewing, and follow-up, documentation and provider notes. Anytime a procedure has to be repeated due to an error within the work process itself, reduces efficiency, increases cost, and decreases your patient satisfaction. And on a very granular level, how are physicians reviewing labs, including textual lab results? Are there multiple locations for the physician to view them? Are they familiar with all of them? And are they familiar what to do with it? That's a singular thread there. What processes are so frustrating that the physician has someone else do them? Where are you in your physician documentation adoption journey? Whole nother topic we could spend multiple hours on. How is that impacting your HIM and revenue cycle work processes? Is that process clear? Is it efficient? Is it being adopted? Are there workarounds being leveraged? Do you know about them? And then how much time is being spent by other roles, supporting roles, working with the physicians to get the information in, right? That's a side-by-side evaluation that has to occur. How many duplicate processes are there because you have disparate systems? Your interfaces aren't fully developed, or they're just it's just disparate. All of these impact the care continuum and all the associated roles. And I'd be happy to talk with anybody else on this call about going more in depth about these.
No, thank you, Lori. So, Dr. Jones, as we think about, it's not all gloom and doom, right? There is a way to empower both our clinical practitioners, our other support staff in the organization to do better, or to be able to work more efficiently and more effectively. But as we think about, the average, I've seen many studies that show that the average provider utilizes less than 60% of the capabilities and functionality of the technology that's been provided to them. What can be done to leverage the technology tools to empower providers with the valuable, sustainable, and repeatable change that those tools were intended to bring?
Right. So, and again, I do apologize for coming across the saying that, no matter how bad you think it is much worse. It is not all doom and gloom. There are approaches, tools, and some great things that are being done out there. I think part of that in health systems have been most effective, like the Reliant Group in Massachusetts. It's the process, their approach to it. I steal shamelessly from Larry Garber and his 3 U's as far as useful, usable, and you. And so that's starting out with, you've got to demonstrate and prove that value to all providers, but in addition, the staff and the executives, so you get the support of whatever that initiative, application, EHR, or process change that you're putting in place. Because otherwise it's, why are we doing this? This is just one more thing that's getting piled upon me. So you have to demonstrate that it is useful in whatever manner. Even if it is meeting the latest and the greatest rules, regulations, initiatives, please explain that to the providers. They will get that. But unless it's told to them or shown to them in terms that they understand, then it's seen at best an annoyance, and at worst another, just one more tremendous burden. The second aspect is that it's usable. In the real world, you can have whatever that tool is, calculator, approach, or whatever. It can be extremely useful, but if it is not reachable, if it is not usable in that real world context, then then it is useless. And so that recognizing that aspect of it. And as a former CMIO, I've been in that position. When you go to the trade shows, when you go, when you read an article, hey, everything looks great in the showroom. Everything looks great at a conference, but actually being able to demonstrate and apply it and make sure it is usable and the workflow in which it's going to be applied is just critical and oftentimes overlooked. And third, and really most importantly, is that you must earn that trust. You earn that trust by listening and being responsive. That you is the stakeholders, the advocates, the initiative, the whoever has bought in and has kicked off whatever that particular change is going to be. And that takes time. That takes time and the willingness to stop and hear rather than just kind of step in and tell. Those are the three aspects, Jeff, that I think is critical to really kind of empower these providers.
Oh, very good. I appreciate that. And I recall back in my role as CIO, it's easy for hospital leadership to get frustrated with clinicians. We've provided these multi-million-dollar systems, and as we talked about a moment ago, less than 60% of the capabilities are being utilized, and people are complaining they don't work well. It'd be like buying someone a sports car and them never shifting out of second gear, right? It's a similar type of burden. So Lori, what additional context could you give around that topic of how to make these things seem more useful, how to ensure that they're usable, and to instill and earn the trust of the practitioners and other clinicians?
Well, Dr. Jones did a great job of, really breaking down the empowerment of it. And when we're speaking of empowerment, it's, when you're driving change, the most effective and efficient change I have found in the work that I've done is when there's a true value proposition, as Dr. Jones spoke to the recipients of that change. So the three U's, it's useful, usable, and you, the trust. You need to identify very carefully who your champions are and how they will be leveraged and heard. Because to build that trust, which is inherent in all of this, in the empowerment growth, is vital. And then those champions help you define what will be measured, which is your value proposition, and how it will be communicated. You're starting to hear my repeating measure and communication. And how will you measure and communicate the wins? How much time will be saved? What is the impact on productivity? Your outcomes, your care management strategy, your quality measures. And then one that's often missed, and this kind of transcends empowerment and deployment, is how will the change be sustained through tools, support, education, communication. So I think that I'd like to bounce it back to you, Jeff, about a further additional discussion on education.
I think that's a great segue. So, Dr. Jones, we know as a physician, your time is extremely valuable. What are the most effective ways for you to receive education and/or information about the changes and the system changes that can help you to better utilize those tools that are being provided?
Well, it has to be clinically relevant. I've seen all too often education being less than optimal because either the scenario just didn't relate or was just plain clinically inaccurate. I've seen more than one time that having PSA value being displayed in an example on a female patient, and you lose the room there. The micro learning, short references, that are bullet pointed as far as how to do a particular task that I was shown how to do, but it had been 3 days, 3 weeks, or 3 months until I've had to actually do that. Then have that education in place that's at my fingertips. I can easily reference it. A picture is worth 1,000 words, and a video is worth 1,000 pictures. So if you can have a functional short video of what you're trying to underscore, then do so. If not, then screenshots, but not death by screen.
Right. Okay, well, thank you, sir. So as we look at the major EHR players, many of them have been focusing on the clinically driven revenue cycle and seem to be coming around to understanding that provider workflow consideration needs to be part of the entire system. And as we think about providers, as I think about providers as a CIO, I've been told several times by physicians, my job is not to create a bill, my job is to take care of patients. I think clinicians also understand that without margin, there's no mission. But have you seen over the past few years that the major EHR players are looking and considering physician workflow as they build their systems, as they make changes to their systems?
They're beginning to be cognizant of it, but building in the workflow well, and particularly the education, what needs to be done, is still really lacking. And your providers are really receptive if you can present the information on, tell me clearly, what do I need to do? Help me out with picking the right codes or right diagnosis. Let me understand, because most of us do get that there, with no money, there's no mission, that every health system needs funds or at least a degree of revenue to kind of continue functioning. And so I think there is a receptibility and appreciation on the provider, and I have found that the major EHR vendors don't really get how to build it in well, and certainly to educate it well as far as the workflow goes.
Thank you. So, Lori, as we think about revenue cycle that's truly focused on, the clinically driven, the clinically required workflow to drive, both physician satisfaction, patient safety, patient satisfaction, what do you see as effective ways of doing it? I know you and I have both been on engagements where our focus was to engineer processes to help drive improvements in those areas. What have you seen as being key drivers?
What I have experienced is those health systems that truly embrace the people process technology process within their optimization of their systems to drive to that, optimized CDRC. Going back to the comment of leveraging your technology, and that goes back to my initial statement of understanding where you are. So you know where you need to get to for your CDRC. What are the pieces, your technology pieces that are in play? What are the providers and clinicians and end users that are within that process? Down to the details, down from the patient registration all the way through, the outpatient follow-up visits. You really have to look at the entire care continuum to effectively drive meaningful change. You need to best case scenario, I've seen health systems that leverage best practice in their communication strategies, their governance model, project management, change management, ITSM, to drive that change is absolutely indispensable. You have to come up with those strategic models to drive that change and sustainability. And to go back to what Dr. Jones was talking about, education, I think that's extremely important. There because of the conversation around clinician burnout, the market is responding. There are tools coming out, micro learning tools that are on our handheld devices. The way that the communication is coming out, because the best laid plans, if they sit in a room and nobody knows about them, are highly ineffective. So I think there needs to be a reassessment of what tools are available. We may not have to buy any more health system technologies. We may need to invest in, a procedure and a tool to push out the technology that you already have in your educational strategy revamping. So that's where I've seen the greatest success, is to really step back, evaluate what's currently going on, evaluate where you need to go, evaluate the technology that you currently have, and the tools that you'll need to deploy the change needed effectively.
Okay, thank you. So, Dr. Jones, as we start to wrap up our session here today, if there were one or two key components or key points that you would like for our listeners to take away from today's call, what would those be?
I guess one, again, recognize and communicate the extent, the impact of provider burnout. The second is, to coincide with the empower, you have to engage and involve your end user. The first rule of change management Fight Club is there is no silver bullet. So it is not one thing that you put in place, you buy and they will come, that will empower. It's really it's engaging and involving the end users in the process. And I would say the third point is be sure to deliver. But be clear of what your purpose is. Again, monitor the optimization, the implementation, the utilization, and put in that feedback loop through education, resources, and support to make sure that you're hitting the mark.
Thank you. And Lori, same question to you. If you were to think of the one or two key areas or key points that you would like for our listeners to walk away with today, what would those be?
So piggybacking off what Dr. Jones spoke about, from my perspective, recognizing the physician burnout impacts others within your health system, and how is that being felt? So recognizing that, and then agree 100% with Dr. Jones in empowering your end users, whether that's providers or other clinicians or other staff, that will have a true impact on the adoption rate, which is all we're going for here. And then as far as delivery, leverage what you have. Are you leveraging what you have? And don't underestimate how a small win can drive great change. You give 15, 20 minutes back to a person's work week to actually do patient caregiving versus doing notes, can have a tremendous impact. And how will you sustain that? So those are my key takeaways.
No, thank you. And I, if I can just quickly give a little of my perspective, obviously my focus is primarily revenue cycle, but there are a lot of little things, as Lori just mentioned, that can be done in your patient registration areas and in your billing and other areas that help drive not only patient satisfaction, but physician satisfaction, physician acceptance of things. If the system is built correctly, if the implementation is done with the clinicians in mind, and that's an area that I think most organizations are focusing on more today than they were 5-10 years ago. But as we look at implementations with the clinicians in mind, the clinicians engaged, that clinician governance of the process, I think that's key to really driving clinical adoption of these systems and better efficiencies. As Dr. Jones mentioned, those educational tools that provide little snippets, little screenshots, and even little video clips of microlearning are very effective and very helpful for clinicians as they utilize the systems. But we would encourage you, any of you on the call today, we have our slide up here that shows some of the other thought leadership that we've provided as ROI. Some of these are webinars, some are little couch conversations, which I'm personally rather proud of. I think they're pretty slick. But we'd encourage you to go out and look at those. But as we close up, Lori and I will both work for ROI, obviously, and here's our contact information. And if any of you would like to follow up with us, please feel free to reach out directly, and we'll be happy to expand the conversation. But at this point, I'd like to open up and see if there are any questions from our audience, and you'd like to address those if at all possible. So please type those into your chat box, and we'll try to address those as we go.
And I'd like to thank Dr. Jones for assisting us with this webinar. Your insights are so valuable. You're living it every day. You're active within the community, and your insights are just terrific. So thank you, Dr. Jones. I really appreciate it.
Well, I've thoroughly enjoyed the collaboration. And this presentation really started out as just a conversation at a conference in the spring, a user group conference between myself, Lori, and Jeff, and kind of develop this out. So I do really enjoy and have benefited from the conversation, putting together this presentation.
Me too.
Okay.
Okay.
I'm not seeing any questions from the audience, so that means one of two things. Either we've put everyone to sleep, or we've done such an excellent job of communicating our points that there are no questions to be asked. But I would encourage, if you have any questions, please reach out, or ask them now. We'll be happy to address them as the group. Dr. Jones, since there aren't any questions from the audience, I do have a question for you. I know we've talked a couple of times about various things, but from a personal perspective, as either in your role as CMIO or that you've seen with your colleagues as a practicing physician, are there any, without sharing names and dates, are there any examples of physician burnout and how that's really significantly impacted organizations that you've been associated with?
Oh, absolutely. Again, my role has changed more recently to medical director of a couple of practices, and within the last 72 hours, I had a stellar provider. They tender her resignation to go to a different practice, with the hopes that it will be a better situation for her. Knowing that other practice well, I don't think it's going to be. My concern is that in a year and 18 months' time, she'll find herself in the same situation that kind of shows her to look for another one, and that's simply a shame. It is a shame that when I've seen patients as recently as 2 hours ago, comment on how I've taken some time to talk and listen to them, and that has become the exception rather than a rule. That can be devastating. Recognizing that it takes time and focus with the patient for them to read back, to really understand what their condition is, what the plan is, how to take their medications, what to do next. And you can only do that by having engaged and inspired providers.
No, thank you. I appreciate that. So I know as a hospital administrator myself, in my past world, a lot of times I viewed physicians kind of as we would view professional athletes, right? And I felt of myself as a coach. Let's just take it to the baseball world, since there's been a lot of conversation in baseball. But physicians and other providers, they have a very specialized skill set, something that I personally cannot do. They are well compensated for what they do, but my job as the hospital administrative staff is to enable them to do their job to the peak and to the maximum capabilities that they have. So that is one thing I always try to keep in mind, and those of you on the call that are in that hospital administrative role, keep in mind most clinicians, most practicing physicians, their primary goal is obviously patient care, but they do want to be good corporate citizens. They do want to do what's best for the organization. Their livelihood is tied to that. And I think if we focus on our roles as being those of facilitators and allowing and providing the capabilities or providing the means for those clinicians to function as effectively as possible, I think we'll all benefit from that type of focus. Lori, as we think about education and training, I know there are a lot of tools out there. Is there anything that you could share around education and learning and training that we could share with this group?
So I've seen an upstart of great tools coming out to assist in that education initiatives being taken on by health systems. We work with a company called MedPower. They do offer a micro-learning tool, which is terrific. It's those short video snippets that it's highly customizable. Also, analytics is a huge portion of it. All the EMRs offer analytics, but quite often you have to have a secondary, more robust analytics tool, but not always. But it's really defining what analytics do you want to measure that have value, because nothing speaks better for value proposition than actual numbers. How do if you are able to give that provider 15, 20 minutes back a week, you need to be able to quantify that. Or if an operation is performed more efficiently and you can measure that within your system, that has value. You can associate a cost or price to that and show a savings. If you optimize your CVRC, you can have a direct impact on your revenue. And I know that's more in your realm, but that's where analytics plays a huge role. So that's where I've seen it, real robust tools for your education and real robust tools for your analytics.
No, thank you so much. So with no additional questions from the audience, I would just like to once again thank Lori and Dr. Jones for a great discussion today on this webinar. Also like to thank each of you for your participation, or giving up some of your day to be part of this presentation as well. But with that, I believe we'll go ahead and sign off and give you 5 to 10 minutes of your day back. We appreciate each one who joined today, and please feel free to share the recorded contents with anyone you feel would benefit from it. Thank you very much.